Thank you all for joining today's webinar on global access to sickle cell clinical trials. We're really excited to join this through and organize this through the Sickle Cell Disease Coalition, and we have lots to cover today. So without further ado, we're going to move forward with going over some of our objectives and the agenda for today before kicking it off to many of our esteemed speakers. So today's webinar agenda, we will give you all a brief overview of the coalition in case you're unfamiliar with us and the work that we do. We'll then pass it over to the many different clinical researchers, advocates, providers around the world that will have sharing the work that they're doing around sickle cell research and clinical trials and enhancing global access. Then we'll pass the torch to some institutional advocates and folks that are involved in also advancing research and clinical trials around sickle cell across the world. And we'll close up with some discussion and Q&A and some thoughts on next steps. So before jumping into today's kind of meat of discussion, we wanted to give you an overview of the coalition itself. The Sickle Cell Disease Coalition was established in 2016 by the American Society of Hematology to unite diverse stakeholders dedicated to conquering sickle cell disease. And this coalition gathers various organizations from stakeholders such as government partners, patient organizations, community-based groups, industry, providers, philanthropies, et cetera, to gather all of these different voices and resources and energy to amplify the voice of the global sickle cell stakeholder community, better coordinate our efforts and foster more partnerships, and ultimately improve the quality of life and outcomes for people living with sickle cell disease. So how we kind of operate, we have a full coalition that meets regularly, but we also have various working groups. And two of our key working groups, the Global Issues and the Research and Clinical Trials Working Group, discuss the need to kind of join forces for a conversation about how they can discuss their various disciplines together and advance the international conversation for research and development for sickle cell. So we're excited to gather them today and join forces for this conversation, but we also wanted to let you know of some communication channels we have in case this would be of interest to keep in touch following today's webinar. We have a SCDC update monthly e-newsletter that goes out that anyone can sign up for. We also have a public Twitter account at Conquer SCD that we encourage you to follow. And lastly, we have our coalition website, scdcoalition.org, with the contact us email at coordinator@scdcoalition.org in case you'd like to get in touch, provide some more questions, thoughts, and continue this conversation after today's webinar. So getting to the meat of what we're actually trying to do today, we would really like to start beginning this conversation, and we know it's not going to be all covered in one 90-minute session, but we really want to begin exploring the current state of sickle cell care across regions throughout the world and learn about what current clinical trials and research are occurring and what opportunities exist for people living with sickle cell disease to participate in these clinical trials, as well as researchers to get involved. And then lastly, we do know that there are quite some barriers that exist, so we want to begin discussing those so we can brainstorm as a community, as a coalition, how we can kind of close those gaps and make sure that there's more access worldwide. So without further ado, I'm going to pass it over to one of our Sickle Cell Disease Global Issues Working Group co-chairs, Bukola Bolarinwa, to kick off today's meat of the presentation with the regional perspectives. So, Buki, the floor is yours.
Thank you, Tessa. Good afternoon, good morning to everyone. My name is Bukola, and like Tessa said, I'm one of the co-chairs of the Global Issues Working Group. This is a topic that's really dear to my heart as someone living with sickle cell disease and living in Nigeria. The importance of a lot of people participating in clinical trials as we move towards the universal cure. The purpose of this panel is for sickle cell researchers and providers from across the world to really provide just a brief overview. Obviously, we know we don't have enough time to go in depth, but to provide an overview of the region's current There are various current infrastructure and the barriers to participating in clinical trials for people living with sickle cell disease. Each speaker is going to have 5 minutes for their presentation, and the regions we're going to be looking at Australia, Middle East, East Africa, South Central Africa, West Africa, Brazil, and the Caribbean in France. And so without further ado, I'll pass it on to our first speaker, who is, I know it's very late over there, so I'll pass on to Dr. Greenway from Royal Children's Hospital in Melbourne. So you have 5 minutes for your presentation. Thank you.
Well, it's very early in the morning, so I'll say good morning to everyone. Thank you very much for the opportunity to be part of this very exciting meeting that we're having today. My name's Anthea Greenway. I'm a haematologist in Melbourne in Australia. To move the slide forward for me. So just in terms of the current state of sickle cell disease in Australia, we're obviously within the Asia Pacific region. We have fairly limited data, unfortunately, in terms of incidence and prevalence. We don't currently have a national screening program, and there is a current application under consideration with our government to consider screening for sickle cell disease within the funded newborn screening program. We have significant variation between centres in terms of screening protocols in pregnancy and for antenatal screening. In terms of what we do know related to the population of sickle cell disease in Australia, there is a haemoglobinopathy registry, which has been running now for the last couple of years. This involves 10 treatment centres with ongoing data collection, and currently we have 352 patients, both adult and paediatric, within that registry. Over 50% are children under the age of 18 and approximately 50% are female. 70% of our patients are actually born in Australia, so that's sort of an interesting statistic. So it's not, sickle cell disease in Australia does not represent purely effective migration. The ethnicity, I think, is interesting because we have quite a disparate or quite a mixed population, which really reflects the multicultural nature of Australian society as well. So you'll see there about almost 60% of our patients on the registry identify as being from sub-Saharan Africa, about 28% from North Africa or Middle East, 10% from Southern or Eastern European, and then the others, as you'll see there. In terms of current treatment, over a third receive regular blood transfusion and 55% of patients are on hydroxyurea. In terms of mortality statistics, that is also unknown, unfortunately, but we do know from the registry that some of our older patients are in their 70s. Current therapies in Australia are significantly limited, and really hydroxyurea is our only disease-modifying agent. We do have a national spleen registry with funded vaccinations and reduced antibiotics, but any of the new medications are currently not licensed. It is possible to import some medications to Australia with a prescription, but practically this is not available. I might go to the, yeah, great, thank you. So in terms of access to current clinical trials, there is some access to medications in haemoglobinopathy, including luspatercept. There has been previous involvement in some of the original gene therapy trials related to beta thalassemia. There's ongoing international collaboration, particularly the Haplo Consortia BMT group, but there are no current active clinical trials in Australia. Bone marrow transplant is offered in the major centres, although we're probably approaching approximately 10 cases, of which more than 90% are in paediatrics and extremely limited in adults, although I do know that there are a number of transplants planned for the next couple of years. And if I was to identify the barriers to both clinical trials and access to new therapies, I think distance does play a role. So the time zone, as I've mentioned, it's the middle of the night here, which makes it quite difficult for meetings and some collaborations. Our small number of patients, so although that number does seem small, most of our treatment centres have seen a 10-fold increase in the number of patients in the last 10 years. Some of the legislative requirements in Australia, particularly for new drugs, can be quite challenging for some of the pharma companies. And one of our other limitations is clinical expertise and specialist care is often focused at the largest centres, and increasingly patients are located in rural and remote locations. So there can be some access issues related to access to care, delays in care, and issues with things like access to TCD, particularly if you're located in an outer centre, and Australia is a very big country to get to screening. We might go on to the next slide. Yeah, great. So just to highlight and thank this group, which is the Australian Haemoglobinopathy Registry. So this includes a number of the providers who care for patients with sickle cell disease, but this is the group who've been collecting that data and will continue to do so. And this is really just a slide to indicate the 10 sort of treatment centres that are located around Australia, and some of the information in terms of our mix of SS versus S-beta versus SC, which is far less common for our population. I think that's my last slide. Thank you very much for the opportunity.
Thank you so much, Dr. Greenway. That was really comprehensive. We're going to pass on to Dr. Salam. If you can see us, because I can't see you, it'd be great to hear your presentation. Dr. Salam.
Yeah, can you allow me to share my screen? Do you see my screen now?
Not yet.
So share.
Yes.
Okay.
We can see it
so
now.
thank you for the invitation, and I'm Salam Alkindi from Sultan Qaboos University in Muscat, Oman, and I'll be touching about some of the in the time allowed for some of the issues that we have in the Middle East. So the Middle East is a very large area, 17, 18 countries, a very large area in both in terms of population as well as in space as well. There are about 500 million people in the Middle East, from Egypt, Iran, Iraq, Saudi Arabia, and so on and so forth. Of course, sickle cell disease is very, very common in this region. The Middle East has about 10 million newborns per year, roughly, but there is a lot of variability in terms of population size, per capita income, health system, and insurance coverage, and so on. But many countries in the region have at least one condition that is screened for by a newborn, in particular Bahrain, Egypt, Oman, Qatar, Saudi Arabia, and the United Arab Emirates, and so on. That does not necessarily include hemoglobinopathy. In my hospital, we have been screening for hemoglobinopathy at newborns for the last 20 years. But these are predominantly hospital-based, but country-wise, there are very few that screen for hemoglobinopathy at birth. The prevalence of sickle cell gene is variable also. If we look at the Gulf, probably the people that have the highest numbers, Bahrain had up to 25% sickle cell gene and 2.3% sickle cell disease gene prevalence. However, that percentage has come down. United Arab Emirates less, Oman 5.8, and then Saudi Arabia actually has a very large population. I will show the numbers now in a minute. And then the rest of the countries probably close to 1% of the general population, particularly in places like Egypt, Lebanon, Jordan, and Iraq. The haplotypes are variable also. So if you look at Kuwait, predominantly Arab Indian haplotypes. Lebanon is less so in Arab Indian and more of African haplotype, particularly Benin. Oman has a Benin haplotype, and about 25% of Arab Indian haplotypes. And we also have Central African Republic haplotypes, but Senegal and Cameroons are not seen in our region. If you look at the numbers that are counted, in Oman, there are about 8,000 patients with sickle cell, Bahrain about similar number, and Saudi Arabia about 70,000 patients. Then there are lesser numbers in other countries in the region. The region has participated in trials. This is actually a paper that was first published from the region on the use of low molecular weight in sickle cell disease. And then subsequently various trials. This is the Brazil, which we have participated, and then other trials also. The diagnostic are reasonably good in our region, and the currently approved therapies, hydroxyurea is available in almost all countries, either free as most of the Gulf region, or subsidized. Patients, the patients in a number of countries have access to novel therapies like reslizumab, foxilitor, and alaglutamine. Some of us have actually participated in some of these trials, and I know countries have some countries have approved these drugs like Saudi Arabia, Emirates, Oman, and Bahrain. But however, it will take some time before all of these become available. Bone marrow transplant is available in many countries in the region: Saudi Arabia, Oman, Iran, Lebanon, Egypt, Jordan, and so on. And we actually been transplanting our patients for quite a number of years. This is our data on about 34 patients transplanted in our hospital, with about 85% event-free survival and overall survival of 94%. There are also some what they call private mutation for the region. There are many, but I just selected. This is an it's called Oman. Is actually these patients are sickle cell trait, but they actually having manifestation. They have a double mutation, a standard sickle mutation of glutamine to valine, but also an O-Arab mutation in the same side of the beta chain. And these patients, although they have a low S level or S-Oman level, here is a patient with an S-Oman and S, so an S and S-Oman. S-Oman migrate in the column close to the C position, so it could be missed if you are not suspecting it. And patients can have up to 20% of S-Oman in their HBLC, and they are having severe manifestations like sickle cell disease. And in the peripheral smear, they show these what they call Napoleon hat red cells. The current availability of sickle cell, of course, there are clinical trials in sickle in Egypt, Saudi Arabia, Oman, Lebanon, and others, mostly pharma initiated, and mostly phase 2 and 3. The current barriers to sickle cell is there are delays in EC approval, transportation of samples, particularly when there are central laboratories, particularly in the COVID time, and the lack of full-fledged research and infrastructure. So these are some of the comments that I want to make about the issues for sickle in the Middle East. Thank you.
Thank you so much, Dr. Salam. That was a very comprehensive presentation. And I know you have some questions in the chat box with some people that just want to have ask you some questions about the situation in the Middle East, so you can reply in the chat. I'll just pass on now to Dr. Julie Makani. If you can take over with your presentation, please.
Thank you very much. Hello everyone, my name is Julie Makani. I am from Muhimbili University in Tanzania, which is in East Africa. I will be speaking on behalf of colleagues who are part of the SickleInAfrica network, which includes countries all across Africa. Next slide. So these are the countries that are part of SickleInAfrica. In Tanzania, we have the colleagues in Tanzania, and then we have Nigeria and Ghana. These are the countries that you can see that are in the darker red. We have a coordinating center in Tanzania and that I'm a part of. And then we have a data coordinating center that is in South Africa that is led by Ambrose Wonkam and Vicky Nambawara. In addition to these three countries that have been funded for the first, for a period of 5 years, between 2017 and 2021, as of 2021, we have 3 additional countries, and these are Mali, Uganda, and Kenya. So in total, SickleInAfrica represents 6 countries, and a data coordinating center in South Africa and a clinical coordinating center in Tanzania. We as SickleInAfrica are part of what we call the Sickle Pan-African Network, which consists of 15 countries and 25 sites within those 15 countries. And those are the countries that you see are marked in a lighter pink there. We need to update this slide, slide, which the image you can see in Lancet Hematology, where we published this work. So we estimate that the global population of sickle cell disease is 5 million people, and the population in Africa is 3.5 million. And this is really back of the envelope estimates that suggest that 75% of the both the birth prevalence as well as the population prevalence is in Africa. So in terms of newborn screening, there has been newborn screening at institutional level in different health facilities in these countries. We also have newborn screening at national level, and this has been occurring in Ghana. This is work led by Professor Kwaku Henefrempong, as well as newborn screening in Uganda at national level. And this is work that has also been published in Lancet Hematology, I think. And this is a collaboration between the Ministry of Health in Uganda and Russell Ware and colleagues in the US. At regional level, newborn screening is under development. There's been discussion to make sure that we move forward from having small newborn screening projects to having regional projects. And Professor Obi has been working very hard with WHO Afro to make sure that this is something that we can do in all the 54 countries in Africa. At multi-site, this is CONSA, this is the Consortium for Newborn Screening in Africa, and this is an initiative that is coordinated by the American Society of Hematology that has 6 countries, and please correct me, Andrew, 6 countries participated in CONSA, and we're really hoping to learn from CONSA as well as from other national and institutional efforts. In terms of the sickle cell positive diagnosis rate, there's limited prenatal and antenatal screening. In terms of newborn screening within the 4 countries, the 6 countries that I mentioned, the birth prevalence which is the positive diagnosis rate, is 4 to 1.2 per 1,000, 1.2 being the birth prevalence in Nigeria, which has the highest birth prevalence in the world. And then we estimate that the population prevalence, and this is based on modeling, but also based on a few studies that have been done where we've been screening at population level. We estimate that the prevalence at population level is 2 to 4 per 1,000. In terms of the registry, so here, this is the sickle cell registry that is part of SickleInAfrica. In the first phase of SickleInAfrica, we screened or we registered 13,000 individuals in Nigeria, Ghana, and Tanzania. And the aim in the next phase of our study is to enroll up to 34,000. This is a registry, I should mention this, that is funded by NHLBI, and our program officer is Dr. Shime Zhu, who you'll hear from as part of this presentation. In terms of mortality rate, I know that the previous publications, this is more than 20 years ago, suggested that childhood survival was very low in Africa. But we estimate now that childhood survival is up to 50%. And this is still very low when you compare to childhood survival in high income countries where the childhood survival is 70%. But this is based on studies that have been done at institutional mainly level in the UK, in the US, and in Tanzania. In terms of the interventions available, most of the countries, in all the countries that we work in, folic acid, PenV, blood transfusion, this is top-up blood transfusion for acute events is available. We've been working increasingly with colleagues in different ways and in different with different approaches. We've been working to make sure that hydroxyurea is available. And here I really want to kind of commend Novartis, because they have been actively engaged in trying to improve access to hydroxyurea. In addition to that, in terms of bone marrow transplant, the only country in Africa that has been able to do bone marrow transplant for sickle cell disease in Africa is Nigeria, under the leadership of Nurse Bazuai in Nigeria. Efforts are being made in Ghana, Tanzania, Uganda to set up bone marrow transplant for sickle cell disease, because as we all know, this is a recommended and an approved curative treatment for bone marrow transplant. So there have been activities and strategies where patients have been identified in country and then sent outside of the country, whether this is to India, to Australia, to the US, but we feel long-term that we need to build that capacity in the countries in Africa. In addition to the work that we're doing in SickleInAfrica, we've also been actively partnering with other initiatives that are listed here, REDAC that you hear from Leon Shilolo after, CONSA, REACH, SickleGen Africa, ARISE, Baba Inusa, Inherent, which is a global hemoglobinopathy network, the NCD Poverty Network, which looks at NCDs, including sickle cell disease as part of the PEN Plus partnership, GGTI, which is a global gene therapy initiative. And then we have, sorry, I keep on, yeah, let me move my thing aside. And then we have the Novartis, as I mentioned, the Novartis Sickle Cell Program, Charter, which is a consortium that we're working on, and then the advanced therapy work that we're doing in Tanzania, Uganda, and other countries. Next slide. So as part of SickleInAfrica, the first 5 years of SPARCO, which is the Sickle Pan-African Research Consortium, we're planning research and clinical trials. And this was divided into two main areas, cohort studies and implementation research. And this is under the leadership of Professor Barbella Brown, who is a physician scientist in Nigeria. So within the cohort studies, we have been looking at clinical epidemiological studies, descriptive epidemiology, looking at anemia, blood transfusion, infections that are led by individual countries. And then in terms of genomic studies, this is led by Christian Happy and Siana Inkia, where we're looking at HbF and F cells, anemia, microbiome in sickle cell disease patients. And because of the COVID-19 pandemic, we have included COVID-19 as a critical area, as well as within the genomics gene therapy. In terms of implementation research, we've been looking at newborn screening. This is work led by Nigeria, Professor Obi, infection prevention, Mali and Aljuma in Mali, and hydroxyurea with work that is led by Professor Sarah. In addition to these cohort studies and implementation research studies, some of them are ongoing, some of them are being planned, and some of them are really designing or looking to see how we will work on this. We're also really making sure that we have patient-centered research that is really working very closely with the patient community to make sure that we partner with them and we understand what are the issues. And last year, we the patients from Ghana, Nigeria, Tanzania, and South Africa published a paper in Lancet Hematology where they were able to share their perspective from as to what it is that they require for sickle cell disease. In addition to that, we're looking at the ethical, legal, and social issues around equity and all the limitations and barriers that we're aware of that to clinical trials. Next slide. So I think this is my final slide. I think the opportunities is that there is now coordination that is really impressive at institutional, national, and regional level that we can leverage. In terms of health and policy, there has been strengthening of sickle cell services at primary, secondary, and tertiary level, and we're seeing the emergence of centers of excellence for sickle cell disease in many African countries. In addition to that, there's development of sickle cell policies, as well as sickle cell included in NCD policies at in ministries of health. In terms of advocacy and engagement, we've been working very closely with patient communities at institutional level, at individual level, and at national and global level. And this is where really there's a lot of learning. I'm glad that Dr. Louis Shu is on the call, where we've been learning from the Sickle Cell Disease Association of America and other sickle cell disease patient communities to kind of learn and see what are the things that we can learn and what are the lessons that we can grow on. In terms of research, as I mentioned, there's research that's been ongoing for many years, and we're just working to leverage this at as a consortium. And I also wanted to just point out that in terms of genomic research, because sickle cell disease is the prototype of genomic research, there is a lot of interest and expertise and investment from H3 Africa and now the DSI Africa. In terms of training, short, medium, long term, online, and of course now with COVID, we've been forced to utilize these resources, and I'm quite excited about the online facilities that are available and exchange programs, both long-term and short-term. And here I would like to point out the American Society of Hematology and the visiting training program that has really, and the HVO program that has really been able to encourage exchanges of both trainees or early investigators and early hematologists, as well as established hematologists. So as an example, in Tanzania, we were able to get a hematologist who came for a sabbatical for a year at his own cost, and we're hoping to host another one this year. In terms of investment and programs, and this is just examples of investment and programs, because there's a lot of perception that there hasn't been investments and adequate programs. There has been investment at institutional national level, public, private, and philanthropy. And I won't go through this, but these are just examples of institutions that have invested, particularly in sickle cell disease. In terms of the barriers, I think one of the things that we really need to address this barrier is this perception that institutions in Africa are not ready. Institutions in Africa are ready, and granted the capacity is limited, but they are ready and they have been doing incredible work. There's this perception that rather than working on personalized medicine where you're saving 100 patients with hydroxyurea, you should do a public health approach. But I am a physician and a heart. And so I do think that these two things are not mutually exclusive. And I think we should really approach it in a way that we do both public health approaches as well as personalized approaches. And from a research perspective, I think it's really important to encourage integrated approach and also encourage basic science research. In terms of the other barrier is the barrier of equity. And fortunately, unfortunately, this is not a barrier that's just limited to East Africa, Tanzania, or Africa. It's a barrier that is seen across all countries. You see this in the US, you see this in South America, that the individuals who have the highest burden of disease are individuals who are Black, and therefore we need to address the same issues in these populations which are high income, and the same issues are in low and middle income countries. In terms of resource allocation, one of the things I wanted to mention here, which comes into the next point, is that we are slowly working to make sure that we address the funding dynamic. Previously, a lot of the funding would go to investigators outside of Africa, and funding would not come to institutions in Africa, and that's slowly changing. And thank you again to the institutions, the funders that are working to make this possible. The other thing is that funding that is being provided in Africa is not being quantified. So if you look at countries in Ghana, in other countries, is that there is funding in sickle cell disease, but because it is embedded either in the Ministry of Education, in the Ministry of Science and Technology, in the Ministry of Health, it's not easy for it to be quantified. Having said all of this, limited funding for sickle cell disease. And I think we need to work together as a global sickle cell community to increase the funding for sickle cell disease globally. Finally, two things is in terms of partnerships. So we've been having discussions, and we've had experience over the past where partnerships are not really encouraged. Although people say that we encourage partnerships, but in reality, partnerships are not encouraged. And so we need to think, how do we navigate around this barrier where a funder will tell you, or an institution will tell you, this is the funding that we've given you to do, please don't get distracted to do X, Y, Z, because you're not funded to do that. So we really need to be able to look at how we can form partnerships that does not go against what we've been funded to do, but also encourages partnerships. There's also this tension between health and research, where you're saying this funding is only for research, or this funding is only for health, and therefore we need to work around that as well. One of the things that's really exciting, and I think I saw somebody post something about celebrities and high-level engagement. I do think that's something that we need to do a lot more of, whether this is high-level engagement with heads of state or presidents, ministries, ministers of health, but also public engagement, so that we have high-level celebrities raising their awareness about sickle cell disease. The final point is really about people. And here really emphasizing the importance of engaging with patients, because if we do not engage with the patients and the patient community, we do not understand what it is that they require. And for us in Tanzania, one of the things that we learned is that we were just saying, bone marrow transplant, gene therapy, this is something that we're not ready to do. And the patients are the ones who came and said, we really want to start looking for that. And if you're not going to provide it to us, we're going to leave the country and go and seek it somewhere else. So listening to patients, really understanding what are the issues that are important to them. And then we are really excited that we do have people in all these areas, not enough, but we're getting there. Finally, it's the whole issue around brain drain and brain circulation. If you've got really good investigators or really good doctors working in a country, next thing you know, they've been appointed to the Ministry of Health, or they've been appointed to head a hospital or a university. And I have had to get my head around that I shouldn't look at it as brain drain, I should look at it as brain circulation. And so knowing that we can really work to make sure that if you have a former person working in sickle cell disease who's now the head of an institution, we look at that as a strength rather than as a drain. And so this is the whole brain circulation issue. Thank you very much. I think this is my last slide. And this is work that I'm presenting on behalf of very, very many people in very, very many countries and funded by many institutions. Thank you very much. Back to you.
Thank you, Dr. Makani. That was a really comprehensive presentation. I think just speaking on Tessa's point, we might just move on to Dr. Idris. Can we move on to Dr. Idris's presentation just to save some time, because I know that we're running quite behind. So Dr. Idris, if you're ready, we'll take your presentation now, please.
Okay, so good afternoon, everyone. My name is Dr. Ibrahim Idris. I'm a hematologist from Nigeria. I work with the Dominican Teaching Hospital, and I'm going to give a short talk on West African perspective in terms of access to clinical research and trial. Next slide, please. Am I in charge of the slide? Okay. So West Africa It's a region in Africa with about 16 countries. There are over 40 million people in the region, and it is the world epicenter of sickle cell disease. So over 50% of the global body resides in West Africa. The prevalence ranges around 0.5 to 2%. In Nigeria specifically is about 2%. There is no universal newborn screening program in the region, but there are many efforts ongoing, especially from ASH Consortium on newborn screening in Africa. Nigeria, Ghana, Liberia are involved. And with this program, they are targeting about 16,000 newborn every year to be screened. There are also other local efforts, especially the St. Jude collaboration with American Teaching Hospital, which I'm very familiar with. This collaboration is targeted to screen about 5,000 newborn with sickle cell disease over the next 5 years. And they have a very robust program of targeting and identifying those people and link them to care. They have a under-7 clinic. So it's still ongoing. There are limited data in terms of antenatal care rate. Mostly I have found only one single center experience. I reported about 0.4% sickle cell disease rate in antenatal samples. Mortality data is still pretty much high since we are aware of the Gariki study, which was done in Nigeria, part of the region, especially Kano. So still, if you look at the prevalence in the adult population, which is about 0.2 to 0.3% compared to the birth incidence of about 2 to 3%, the prevalence is tenfold lower in the adult population. This underscores the fact that mortality is pretty much high during the childhood up to the level of adolescence. In Nigeria, they said about 5% of childhood mortality is contributed by sickle cell disease. Currently, many drugs are available in the region, especially the supplements, folic acid, the antimalarial prophylaxis, the penicillin B and hydroxyurea is increasing acceptance because of the evidence showing that it's a disease-modifying agent, really helping patients in terms of reduced mortality, reduced organ complication, and quality of life. Nigeria also provides a low level of transplant, as mentioned by the previous speaker. There's a physician in Benin who has done about 10 transplants in sickle cell disease patients. Apart from Nigeria, I'm not aware of any country in West Africa that provides bone marrow transplant. Newer drugs like crizanlizumab, inclacumab, boxylator are currently being tried in the region, but they are not being approved for use. They are all under the trial at the moment. Next slide. So if we look at West Africa, what is glaring is there are very few investigator-initiated clinical trials. From the registry, we could only identify about 4. And out of these 4, all of them are conducted in Nigeria. So one of them I'm leading it, which is the support of the ASH Global Research Award, which we are targeted to recruit 100 participants to see if we can prevent recurrent ischemic priapism. The other one is also a collaboration between Vanderbilt University and my teaching hospital in Kano. They are trying to see if they can prevent malnutrition in children with sickle cell disease. The also glaring thing about this trial is none of them is funded by the Nigerian government or any West African government. They are mostly funded by partners from US, Europe, and America. So we still like funding locally for these investigator-initiated clinical trials. However, there are also ongoing observational studies, which some of them cut across Africa regions, particularly the heart, artery, and sickle cell disease, which is funded by the French government, and it's a very large cohort with 4,500 participants. There's also a large registry in Kano also, which is targeting to see if they can document the incidence of stroke in adolescent and young adults. Next slide. So in contrast to the investigator-initiated clinical trials, industry-sponsored clinical trials are getting more prominent. From the registry, we could identify about 2-fold increase in the investigator-initiated clinical trials. So most of them with GBT leading the race. About 3 of its trials are currently being conducted in West Africa. The one for TCD, trying to see if they can reduce conditional TCD. There's a new drug being tested which target P-selectin, and they have an open label extension of that. Novartis is also conducting a clinical trial in Ghana with the crizanlizumab, and there is also a new molecule which is phosphodiesterase 5/9 inhibitor, which has been tested also by a company, MRI-NSC. Hydroxyurea is also being tested by a company, Admedica, which is trying to see the effects on albuminuria in a phase 2 clinical trial. So these are the publicly available researches that are ongoing or about to be completed in West Africa region. Next slide. So the various clinical research trials in Africa are similar to most of the lower middle income countries. There is issue about adequate skilled manpower with dedicated research team to conduct this. And this is because they can find a country that has very few hematologists, and these hematologists attend to all other hematological diseases. So having focus becomes difficult in that setting. And this is also affected by the fact that we still have issues about brain drain. The people that are well trained are also leaving the shores of the country or the region for greener posture. There's issue about funding. Most of the funding are coming from outside the region. And we don't have much local funding. All the researches are funded by countries that don't have the high prevalence of sickle cell disease, which shows there is lack of motivation from the countries usually to fund research. Most of the money goes into programs rather than research. There's also inadequate biostatistical capacity. So many countries, you don't have, if you want to have an investigator-initiated studies, you need to have a strong biostatistics. And if there is no biostatistics, your grant is likely to be funded, no matter how beautiful the idea is. So this is something that should be addressed as part of the challenges in the region. Electronic medical records are also absent, and this affects the quality of the data. Sometimes people are generating, because you collect information on loose paper sheets in a form of folder. And sometimes if you want to go back to review history, you find out that those papers can be missing. And this is something that is very important also if you want to improve access to research and quality of the data. Infrastructure is a challenge. I could remember when we wanted to do a stroke prevention in sickle cell disease. We wanted to look at the silent impact. Within the 400-kilometer radius of northern Nigeria, we could only find one single MRI that can do, that have 1.5 Tesla capacity. So if you have something like that, no matter how beautiful the idea is, if there's no infrastructure to support it, you can have to abort it. And again, even the biorepository capacity is also lacking, and because electricity is a challenge in most of these countries, sometimes storage samples can be problematic, so you can have other challenges. There's competing demands. Most of the clinicians are overstretched. They have to do their clinical work, see thousands of patients, also at the same time participate in administrative and academic programs. And this is really challenging because it doesn't allow people to really have focus in what they're doing. You find the same person, he's an oncologist, he's serving as a hematologist, he's a thrombosis expert, and that will really affect his performance. And if there are more, and this underscores the fact that we don't have investment that produces enough people to have focus in this area. We still have challenges with regulatory barriers, especially in the terms of the FDA equivalent of this organization. I have an experience that since I got my funding to do my clinical trial, I'm still struggling to get the Nigerian version of FDA to finally give me approval to start the trial. So sometimes people can lose funding waiting for the approval from this organization. I can understand that in terms of the ethics approval, there is a lot of improvement. Local ethics committees are now improving, but the FDA equivalent aspect still has a lot of bureaucracy. Again, the sustainability of the care. Most of these participants of the trial will participate in this trial, but at the end of the trial, they cannot afford some of these drugs that have been tried. So because of the lack of health insurance, which barely 5 to 10% of the people in the region have insurance coverage, if you participate in the study, eventually you may not benefit from long-term effect of the drug you have participated. So people will feel like they are serving just as guinea pigs in the studies. They will not eventually benefit from the studies they have participated. So this is also important for the countries in Africa to invest more in healthcare, universal access, and universal coverage. So with this, I've come to the end of my presentation. I want to thank you for giving me the opportunity to share our experience from West Africa region.
Thank you so much, Dr. Idris. That was so comprehensive as well. And yeah, really very, very relatable from my perspective. So we'll quickly move on to Dr. Mariane to give us a perspective for Europe. Dr. Mariane.
Thank you very much for this invitation. I am going to talk about France. I am working in Paris, and I will also talk about Europe. I am a member of the EHA board, and I will talk about Europe as well. Next slide, please. Indeed, sickle cell disease is highly important in Europe since it is endemic in some European countries, such as Greece or Turkey. Since, as you know, several Caribbean islands are part of European countries. We all know there is a history of colonization, and many people living in Africa are French-speaking persons. And we have a continuous afflux of refugees from populations with a high prevalence of hemoglobinopathies. Next slide, please. Here you can see the report about asylum applicants to Europe, and you can see that a lot of people are coming. These are the data in the past one which were recorded coming from Nigeria, South Africa, Somalia, Senegal, Ghana, and all countries with a high prevalence of sickle cell disease trait. It was published 4 years ago. Next slide, please. Epidemiology, finally, the best report I could find about the epidemiology of sickle cell disease in Europe is coming from our friend Stefan Lubitz, who published it recently. If you make on the right part of the slide, you have the estimated number of patients with sickle cell disease. If you make the sum, it makes 40,000 patients with sickle cell disease in Europe. On the left part of the slide, you have countries with a star. Those countries with a star are those where there is systematic newborn screening of sickle cell disease, such as England, France, Netherlands, Spain, and in other countries, it is not yet systematic. If you look at the numbers on the right, you have some data coming from registers and other coming from expert opinion. Can you just there is an animation, if you can go on with this slide. Animation, please. Yes. So, and when you look at those data, you can see that 4 years ago, there were 250 newborns affected with sickle cell disease screened in the UK. And 2 years ago, 600 newborns affected with sickle cell disease in France. France appears as the European country with the highest number of patients with sickle cell disease. And just move one click, please. Yes, and we published recently, past year, data showing that we recorded not 15,000 patients with sickle cell disease, but we estimate, or we can show that in France there are, for instance, 30,000 patients. So finally, we can get that the number of patients with sickle cell disease in Europe is not 40,000, but most probably around 70 or 80,000 patients living with sickle cell disease in Europe. Next slide, please. The median survival of patients is high in children. These are the most recent data in France and in the UK. And we can now, thanks to systematic screening and all the measures that you know very well, 95% or 85% of patients with sickle cell disease in France and in the UK are reaching the adulthood. And I can see that in Ireland, it is the same result on the chat. Next slide, please. Nevertheless, the life expectancy is still really shortened versus the non-sickle cell disease affected people. These are the data from my friend Anusha Habibi. She works in Henri Mondor, and on a cohort 3 years ago, she showed that median age at death was 37 years, mostly related to acute organ failure occurring in patients with pre-existing organ damage. Just to go ahead, please, it is animated. Next slide. Yes, okay, thank you. And at the ASH this year, she published an update, and you can see that the median age at death is no more 37 years, but 41, which is very young. And it is in line with the data from the United States, which were published at 44 years of age. And I think that there is a colleague from Brazil, and Rodolfo Consado showed that the median age was 32 years in Brazil. Next slide, please. I have tried to make a summary of what is present, what is going on in Europe, and not only in France. What is we share in many countries a neonatal screening, and all care is totally free with equal access. People have not to pay for anything. Even for bone marrow transplant, it is totally free. What we share, unfortunately, is insufficient training of GPs and first-line centers, insufficient training of school, university, and professional stakeholders. And we are not very good in pain management and transition progress, which need to be improved almost everywhere. Next slide. And what we share are variable levels of knowledge and expertise in different European countries. And we do not have a common European guideline. We have national guidelines with strategies highly different, especially concerning hydroxyurea protocol. UK has decided as the US a systematic proposal to all children, and it is not the case in all European countries. In hydroxyurea, of course, is totally free. For instance, in my center, 70% of the patients are treated with hydroxyurea. Next slide. About research, we have Europe has built a European network about long-term use of hydroxyurea, allowing us to publish recently a follow-up of more than 7,000 patient years observation, 7,000 patient years of duration of hydroxyurea exposures, which is the longest hydroxyurea exposure report. We are not only participating to ongoing trials using crizolizumab, voxelotor, or PK activators, but in almost all countries, these drugs are available and for free for patients. Crizolizumab and voxelotor, PK activators are still ongoing research. We have participated to all cohorts on bone marrow transplants and gene therapy. On the bottom of the slide, there is a trial which was published in France, the first success of gene therapy in a patient with sickle cell disease who was cured by gene therapy in 2014. And we are participating to all trials about CRISPR-Cas9 gene editing. And I have put the list of the authors, and you can see there are a lot of European authors. Have underlined progressively what were the limitations and problems, and it is my last slide, and thank you for your attention.
Thank you so much, Dr. Mariane. That was really comprehensive. I didn't even know there were that many people with sickle cell in Europe. So we're going to move on now to Dr. Marimilia. Apologies if I mispronounce your name, who will give us the perspective from Brazil.
Good morning for all. First of all, I'd like to thank the Sickle Cell Disease Coalition for inviting me to participate in this webinar. And I'm pediatric hematologist. I work at Samaritano Hospital. I'm founder of the Pediatric Committee in Brazilian Society of Hemotherapy, founder member in the board member in Global Alliance, Sickle Cell Disease Organization. And I'm here today to talk about sickle cell disease in Brazil. Next slide, please. Well, population of individuals living with sickle cell disease. As everyone knows, Brazil is a country of continental domination. We have about 200 million people living here, and we have about approximately 60 to 70,000 patients with sickle cell disease. Newborn screening test is performed in about 80% of Brazilian maternity hospitals, but unfortunately, we don't receive this data directly, but it can have access to it. Positive sickle cell diagnosis rate, we have about 3,500 children born with sickle cell disease per year in Brazil. And our mortality rate is about 490 patients per year. In Brazil, as we have these dimensions, the situation alone is enough to make difficult the access for sickle cell disease patients, especially in the northwest part of the country, which is the poorest and exactly where we have most of the patients with sickle cell disease. In São Paulo, where I work, that is the richest state in Brazil, and however, it's not the biggest one. We have about 40 services treating sickle cell disease patients. But even in São Paulo, despite having the best service, we still have many difficulties with the access of these patients. Well, about the current therapies approved. Hydroxyurea is, the Ministry of Health provides hydroxyurea for every patient with sickle cell disease. But unfortunately, we know that only about 70% of the patients use this drug only because the hematologists don't prescribe it. Tislelizumab, we can, it's okay free in Brazil now, but we are using it only in clinical trials. Bone marrow transplantation is done in most of the services and with great results in sickle cell disease. Next slide, please. About the current availability of sickle cell disease trial. Talking about research, we have many important hematology centers in Brazil that perform clinical research. However, our great challenge is to make healthcare providers from the smallest centers with less infrastructure to participate in this research. Many of them don't even attend congresses, webinars, etc. But it's very important to add that the Ministry of Health even has research to support researchers. However, it doesn't have demand for the project. About current barrier, one of the biggest problem with sickle cell disease in Brazil is that we still don't have a national registry, and therefore we have many problems in recognizing our profile, recognize the epidemiological profile of our patients. We understand that making it possible, we will be able to create conditions for the implementation of public policies more appropriate to this disease, improving clinical treatment and consequently the quality of life of these patients. not to solve this problem. A partnership is being signed between Brazilian Hematology Association and the Ministry of Health, steering program, but we will already have about 30,000 patients already inscribed. I thank you very much, and it's all for today.
Thank you so much, Dr. Pita. That's really comprehensive and succinct as well. We'll move on to our last speaker, Dr. Asnani, who will give us the perspective from the Caribbean.
Good morning, everyone. Thank you so very much to the SCD Coalition for having us here. Could I share my own slides, please? I have them right here. Thank you so much. I'm disabled.
Correct that 1 second.
So I know we are running short on time. Who can share? Am I able to go?
I believe you should be able to now.
Yeah. Okay, great, great. So the Caribbean is really a large area and quite a varied area. It has more than 700 islands, and you will all know where the Caribbean region exists. There are 13 sovereign states and 17 overseas territories and dependencies. 43 million inhabitants, which is just about 0.56% of the total world population. There are more than 5 official spoken languages and definitely many other dialects. What's the state of sickle cell disease in the Caribbean regions? Whereas there are many territories that have a lot of focus on sickle cell disease. For example, in Jamaica, where I am, Guadeloupe, Martinique, Cuba, there are many areas, many countries that are still very underinvested in sickle cell disease. And the presence of champions, as we like to call them, in certain regions is where there is a lot of focus on sickle cell disease. So this is how it happened in Jamaica with Professor Graham Sargent's work in Jamaica, him being a champion that brought a lot of focus on sickle cell disease. And we have those champions in other regions, thankfully. We're hoping to grow that. So if you look at this slide on global incidence of sickle cell disease, even though, as we said, the Caribbean population is less than 0.6% of the global population, the incidence of affected births is second only to Africa, okay? And the percent of total annual affected births, just about 1.2%, but the incidence is second only to Africa in the Caribbean. And this is a slide that we do a lot of work. CARIS is our Caribbean organization. It's called the Caribbean Network of Researchers in Sickle Cell Disease and Thalassemia. It's headquartered in Guadeloupe, which is a French territory. But the Caribbean has really gotten together in this organization. And we have done some work. There are different regions that have newborn screening, universal screening at different times. And there are some that were engaged in pilot newborn screening programs through different collaborations and funding mechanisms with the hope that governments and regions will continue their own universal screening programs. It has not been achieved everywhere yet, but we continue our work. Other than Cuba, where there's prenatal diagnosis, you can see that the carrier prevalence, which includes HBS and HBC traits, ranges from 10 to 15%, and the prevalence of sickle cell disease in new births in Jamaica is about 1 in 150 live births is born with a sickle cell disease, and you can see the prevalence in other parts of the Caribbean. Newborn screening testing in the Caribbean. Again, Guadeloupe does testing for Tobago, for Grenada, and HPLC is the first test, IEF being used for confirmatory testing. And these are the other regions. Jamaica definitely does. We are doing newborn screening, universal newborn screening, even though Jamaica is where the first work on the importance of newborn screening came out of from the work in 1973 to 1981, the first the largest sickle cell newborn cohort, but we did not achieve universal newborn screening till about 2015, 2016. St. Lucia has done some through projects, and so definitely the French territories are all doing newborn screening. Mortality rate data is not very clear. In Jamaica, we have a very early paper that spoke to estimated median survival in the 50s, but a more recent paper looks at median survival and this again is the Jamaica Sickle Cell Cohort study at 42.3 years for males, 40.2 years a median for females has not yet been reached. Guadeloupe, so even in Jamaica, the life expectancy is about 25-30 years below the national figures. In Guadeloupe as well, the national figures is about 30 years less than national figures. What about the therapies in the Caribbean? So hydroxyurea is accessible in most territories. Actual utilization figures are uncertain, of course. So even in Jamaica, where the drug is subsidized by the Ministry of Health and Wellness National Health Fund, but yet is maybe utilization figures maybe less than 10% of patients with sickle cell disease are using it, and we need to assess the barriers, but it's available in most countries with varying utilization. When you look at emerging or novel therapies, so glutamine for Jamaica is only available in health stores, so we do not have it licensed. And quizanlizumab, voxelotor, even though we were one of a key sites in clinical trials with both of these drugs, they are not available. They are not licensed for use in our country yet. Martinique and Guadeloupe, again, French territories, just ad hoc use, temporary authorization of use of the drug, but financial constraints do not make it accessible to everyone. In Antigua and Barbuda, where we got some numbers, is one patient on glutamine with hydroxyurea, but the other therapies are really unattainable right now. What about research and clinical trials access in the Caribbean? The picture is varied. I'll speak to the barriers first. I believe there's lack of opportunities as sponsors and collaborators may not always be familiar. So this coalition and this webinar is really key because I've learned so much listening to our global friends speak to their works with sickle cell disease. So there's lack of opportunities maybe that people may not be aware that there's expertise available in definitely some regions within the Caribbean. Most of the regions that do conduct trials are limited. They're small teams, even in Jamaica, unless we are supported by research funds, there are delays in administrative and other processes, again, due to small numbers. All of this has been worsened by COVID. Import and export delays in sourcing materials. We may have resource restrictions, freezers, sophisticated investigations locally, for example, cardiac MRIs. There's lack of Caribbean-based CROs to really guide us and take us through. So that expertise is lacking within the Caribbean. And many regions will say there's a lack of everything, lack of access, lack of training and expertise in conducting clinical trials, lack of staff, funds, facilities, and regulation. So the regulatory framework may not exist. Talking to Jamaica, the Sickle Cell Unit, and I'm the current director for the Sickle Cell Unit in Jamaica, we are part of a research organization, which is the Caribbean Institute for Health Research. So our mandate is to conduct research. So we have a history over the last 4 decades, history of both academic-led and more industry-based trials. As I said earlier, we have participated in novel therapies, the HU studies, because there's local interest in our academic team, looking at hydroxyurea trials, Extend, and the NOVA trials, looking at the liquid HU preparation. And we are currently engaged in a gene therapy trial with Cincinnati Children's Hospital Medical Center. What are some of our strengths? We do have a fairly strong infrastructure with access to legal, ethical, and technical frameworks in Jamaica. And we have trained and experienced research teams. Our research team is tiny, but quite a few years of training and experience, dedicated patients. We have a large clinic load in Jamaica. We estimate about 18 to 19,000 persons living with sickle cell disease in Jamaica. The unit has on board over 5,000 patients actively being seen. About 3,000 patients are seen every over the year, and we see all ages, babies to elderly. Our oldest patients are in the 80s. Strong patient peer group. We have the Sickle Cell Support Foundation of Jamaica, which is a strong partner with the sickle cell disease profile in Jamaica. The ministry is very invested in sickle cell disease as well, the Ministry of Health. There's good communication with all stakeholders as well. And Guadeloupe is the other center. There's a coordinating site of the Antilles Guyana Reference Center for Sickle Cell Disease. It has close working collaboration with Martinique and French Guyana, and belongs to the French National Health Network for Rare Diseases and the Euroblood Network. So that allows them to regularly participate in clinical trials. And yet they do have strengths, which is the presence of a clinical research department and willing patients again. You know, our patients tend to have a lot of confidence, and so they are more willing to be participants in our trials. So I'll stop there. You know, we could spend a whole day looking at sickle cell disease in the Caribbean, but thanks again for the opportunity, and I'm happy to answer any questions. Thank you.
Thank you so much, Professor Asnani. That was a really comprehensive presentation as well. We've had some really, really great presentations today, great speakers. And that brings us to the end of this part of the session today. I know that we're running a little bit over time, so I'm just going to pass on quickly to Tessa to tell us what we're going to do next.
Sure. So we're full disclosure to everyone that we knew we had an ambitious agenda today and a lot to cover, and wanted to get as many folks involved. And I think we've gained such great information about the international status. So we are definitely planning on having a round 2 of this conversation, where we'll have more time dedicated to folks and bring in new voices. But since we did have 2 great presentations already prepared today, I'll let Dr. Zhu and Dr. Boateng let us know if you'd prefer to present today or save your presentations for our part 2 conversation.
Yeah, I can present today. So this is Simeon Zhu from NHLBI.
Awesome. And Dr. Boateng, I will let you make your own call, and we can include you in a part 2 if that's your preference, or do today, whatever you prefer.
Yeah, I think at the end, I'll just show a quick highlight of what our research platform is, not give more detail during the part 2.
Perfect. Well, thank you all for your patience. We're not going to cut it off at 10:30, so please feel free to hang on with us if you've got the time. But I will pass it over to Sam to introduce our institutional presenters, and we'll move forward with Dr. Zhu's presentation. Or without the pompous and, you know, all of the things that we've been doing, we can just get into the meat of Dr. Zhu's presentation from NHLBI. So Shimian, the floor is yours.
Thank you. Thank you, the organizer, for this opportunity to present our support of sickle cell disease research. In addition to my division, as Division of Blood Diseases and Resources, our science policy, engagement, education and communications office also provide input. Next, please. So this institute includes both intramural and extramural. The Division of Intramural Research supports research both in the sickle cell branch, which is mostly basic research, as you can see, and also the cellular molecular therapeutics branch, which is working on multiple strategies, both in the laboratory and in the clinic, to cure sickle cell disease by repairing or replacing the precursor bone marrow cells that gave rise to the sick red blood cells, and also exploring gene editing tools to correct the underlying mutation which cause sickle cell disease. Next, please. So in my own division of blood disease and resources, so we support the research to stimulate and then through grants and contracts to support sickle cell disease research to understand the underlying pathogenesis, to evaluate promising therapies and to improve clinical care. And also we facilitate the translation of discoveries into therapeutics. Basically, we issue various of funding opportunities of like program announcement, for example, for R1 grants, and also program announcement with review or PAR, request for application or RFA, a request for proposal or RFP, which supports research contracts. In addition, we have specific PARs for clinical trials, including the parent one for mechanistic studies or single-site clinical trials, as well as the clinical coordinating center and the data coordinating center for multi-site trials. Next, please. Yeah, this is an example of one of the studies we support. It's called Sickle Cell Disease and the Cardiovascular Risk Red Cell Exchange Trial. It's a phase 3 randomized multi-center controlled trial. The hypothesis is obviously red blood cell exchange transfusion will limit disease progression, improve access capacity, and to basically improve the or prevent various episodes of conditions and improve the health of adult sickle cell patients at a higher risk of death. For details, you can look into the clinicaltrial.gov webpage. Next, please. This slide shows the recruitment of participants. As you know, for many clinical trials, the major challenge is recruitment of participants. But as you can see, this trial has been going on very well. Next, please. And also the major initiative this institute is supporting is called the Cure Sickle Cell Initiative. The initiative is to accelerate the development of genetic therapies aimed at curing sickle cell disease. For details, there's also a website, so you can check the website for details. Next, please. So basically, this initiative is supporting a phase 2 clinical trial using a novel gene therapy approach. And another is a phase 1 clinical trial using a novel gene editing approach. And also there's a development of non-genotoxic conditioning regimen for transplant. And then the impact analysis and also a prospective study for long-term clinical and meaningful patient-reported outcomes. There's also a cell bank resources which can provide the investigators with access to critical biospecimens for further research. And also advancement of robust, reliable laboratory assays. Next, please. Yeah, this is a trial we supported. Is close to be complete. It's still active, but not recruiting anymore. It's in the further data analysis. It's a phase 1/2 open label hydroxyurea trial for children with sickle cell anemia. Next, please. So the findings have been published in the New England Journal of Medicine in December 2018. So for details, you can read the paper which I cited at below the slide. Next, please. Yeah, this is another trial which is under preparation to be launched shortly this year. It's a randomized multi-center open label trial of hydroxyurea for children with sickle cell anemia in Africa. Next, please. Yeah, this is a program Dr. Julia Makani already covered very well, so I'm going to run over the slides very quickly. Basically, which includes the SICK Pan-Africa Research Consortium led by Dr. Julia Makani, together with the SICK Africa Data Coordinating Center led by Dr. Ambrosi Wellcome, as Julie mentioned, which was founded from 2017 to 2021. Next, please. So that phase of the program basically complete a lot of tasks, as Julia mentioned. For example, a registry of over 13,000 cases, and also the shared database elements and harmonized phenotype definition ontologies, which is a huge achievement. As you know, for research, it's critically important to have a common data elements and standardized definitions. So this has been shared on a website, which has been actually used by many investigators, clinicians outside of the program. So it was a huge achievement. And then management guidelines, which also, as far as I know, has been shared with other organizations, including the World Health Organization. So it's also something should be proud of as well. And then the skills development and also plan the studies. Next, please. Yeah, that's the current phase. As Julie mentioned, that's a clinical coordinating center, again, led by Julie. Dr. Julie Makani, and then the data coordinating center still led by Dr. Ambrosi Wellcome. And then the three existing sites in Ghana, in Nigeria, and then Tanzania, plus 3 new sites in Mali, in Uganda, and Zimbabwe, and Zambia. Next, please. Yeah, that's what the current program plans to do, which Julie mentioned already, but actually I just highlight basically to more accurately describe the current status of the disease, as well as risk modifiers, and then permit the evaluation of incidence, clinical events, and the possible association with various factors, and also impact on health outcomes. Currently, the program is developing a cohort and the implementation science research protocols under the leadership of Julie and then Ambrosi, and as well as the other site PIs, principal investigators. Next, please. Yeah, this slide just shows the sites. Actually, Julie showed a more comprehensive map already, but here I just show the 3 programs. One is the SickleInAfrica consortium. One is the REACH trial for hydroxyurea, and then the SCD program many of you are aware of. Next, please. Yeah, this is just to, that's the contact information for Sickle Cell Disease Research Program, and the programs is on the NHLBI website, as I indicated here. And for questions, that's email address, that's phone number. Thank you.
Thank you, Dr. Zhu. I think that was a great way to round out some of the research that's ongoing. And we're going to frame this a little bit of a preview of our next webinar to come. So Stephen, I know that you've got a lot of great work that you're doing to share, so we want to highlight that properly, but I'll let you close us out with a little bit of preview and update of what you're doing at Sickle Cell Studies.
All right. Thank you, everyone. I think I'm the last person here standing in between everybody, whether it's lunch, going to bed, or anything like that. So hopefully I'll be very quick. Can you guys all see my screen? Perfect. So, I think what's been really clear from all the conversations today is the fact that, collaboration needs to happen with research. And I think what's really important, I think everybody on this call will agree, is that we always have to keep the patient at the forefront of what we do. So we at Sickle Cell 101, we've created this platform, which is really, its aim is to really help patients identify clinical trials, but also help engage and educate them in a form that they can easily understand. And that's kind of something I'm just going to tease you guys a little bit with. And then during the follow-up, I will share more with you guys. So this platform is called Sickle Cell Studies. I won't go through the overview because this is a teaser. I think I already talked about the current state of global access to clinical trials, and I think most of our speakers already highlighted this. I think what is clear is that there's a huge unmet need when we think about clinical trials globally, right? There's a lot of work going on in the US, Europe, but most other countries. There's more that we could do. I think that is pretty clear. So one of the things that I want to share is always thinking about lessons learned, right? So we've had a couple of lessons learned, and I think it was Dr. Julie Makani who spoke earlier about, kind of perceptions and misconceptions around the fact that most other countries are not ready or patients are not interested. I think what we've learned from Sickle Cell 101 through our global platform is that there's interest and appetite with patients, specifically wanting to engage and enroll in clinical trials and even surveys. So I'm just utilizing this survey study that we ran a few months ago related to COVID-19 vaccines. And I think the key takeaway here is that patients ex-US and Europe are always interested in finding clinical trials. They just have a lot of questions that we hope we can help address. I think one of the things that I want to highlight before we leave today is reminding all of us, and I think we all know through that study, we did learn that, that trust that we always talk about between the patients and medical community and research, I think we've done such a great job overall. And I think we also give credit to each other for the work that we've done, but there's still more work to be done. And I think that's a big part as to why interest around clinical trials and even surveys, sometimes there can be a barrier, even in the US and even ex-US as well. So how are we able to build this trust, right? What's the goal, or what can we do to help with the trust? And one of the things that I want to talk about is through that survey, one thing we learned quickly is that for patients that had more information about, let's say, how vaccines work, how vaccines are enrolled in clinical trials, those patients are more likely to be willing to participate or get a vaccine. So I think we can incorporate those lessons and think about clinical trials the same. The better way we can educate these patients to understand the studies and all these key terminology, I think the more interest we can garnish from the patient community, not just patients, caregivers, and different advocates. So our research platform really helps address a lot of these common terminologies and concerns. Key takeaway in a patient-friendly language. We try to simplify this content so that these patients can really understand it. I think we all know it's great that we have, study investigators and principal investigators running studies. But with these days in technology, patients are also looking. They're the ones trying to find all these studies. And there's a lot of concerns that comes up. And this is through our own research. And these are some of the top concerns that have come up. And we've tried to resolve that to help build the trust that patients will feel and confidence for them to enroll in clinical trials. So again, I'll touch more about our platform later on, but just to share with you guys briefly, what we've done with sickle cell studies is really build a patient-centric platform that patients can find a couple of key things on there. So again, it's all about the patient. Everything on here is very patient-friendly and making things easy for them to understand. So if you go on the website, what are some of the things that an individual is going to see? They can already get access to all clinical trials that are recruited globally. The keyword is recruited. We even take it a step further, and I think there's a lot of partners on this call already that we're working with to really even make their study profiles more patient-friendly so patients can easily understand those. They can also learn about clinical trials, but key takeaways, they can also learn about what other patients or other community members are saying, because one thing that we do know, and we have a lot of data to back this up, is that the sickle cell community, they learn from each other, and it's important that they can see what those successes look like. So briefly, this is what our research platform looks like. Again, I'll share more at a later time. When you go on the platform, like I said, there's a clinical trial locator. It even includes a global part as well. But most important, we have a registry as well, and I'll touch on briefly in a few minutes. This registry really helps patients have a voice, tell us more about some of the topics they want to hear about, but also help address the concerns. And we have a section on there dedicated to educational resources only, and of course, helping patients engage in questions. So this platform is really built to the patients in mind, but also collaboratively with most of you on this call already, whether it's different from Circle partners, individual universities, you name it. And one thing we've tried to do too is, outside of a patient finding a study that is recruiting, the partners that we work with try to customize their profiles to make it very patient friendly, very simple, so that patients don't have to worry about the details they have to read. Maybe if they went on clinical trials, there might be clinicaltrials.gov, there might be too much information. So this is an example of one study we have ongoing with University of Pittsburgh. We put a simple video in there so patients can easily understand what the study is about and what they're trying to enroll in. This is priority. This is our registry priorities, patient-reported input and outcomes through research by the sickle cell community. This is where the community tells us what they want to learn more about. So we constantly engage with the community, but I think what is really important, one of the biggest requests that we get is patients in the community always want to learn about the outcomes of a lot of the studies that they enroll in. So we try and do our best to ensure that all the partners that we work with, we can always share back some of those studies too. I think one of the things that is important as you guys look at this first picture here is the community is always asking about treatment, right? They always want to learn about all these clinical trials. And I think the community informing us is really important because they are the ones that are ultimately going to make a decision whether they enroll in a clinical trial or in a survey or not. All right, just a highlight here showing you guys what our clinical trial website looks like. It's one of the things that people can find, whether it's from a local perspective or from a global perspective, and they can customize it based on location and all things that are interested to them. Again, as I kind of wrap this up, I think what is important is that reminding the community and everybody on the call that there's a learn portion of this website that really helps the community ask questions, right? Some of the concerns that they always have, and also helping them understand some of the successes as to why clinical trials came to be for sickles and why they should probably be encouraged to enroll in clinical trials. Something as simple as even educating the community members about what are the key milestones of a clinical trial. To most of us scientists, these might be second nature to us, but even helping the community understand some of these things, even the informed consent, what a protocol is in a patient-friendly way can really help build that trust and help patients feel confident in enrolling clinical trials. The platform also helps address those common concerns I talked about. This is all a teaser. I'll share more information about all of this with you all later. But I think the key takeaway here is that we do know the community is the most important aspect of clinical trials and research, and we always have to find a way to meet them where they are. I'm going to skip straight to kind of the conclusion, but most of these slides I'm forwarding to just kind of shows you guys about what are some of the things you would see on the website. And I encourage everybody to go on there at your free time to take a look at some of the work that we are doing to really help the community build trust within research and also get interest in participating in clinical trials. So to summarize everything that I've kind of talked about, which is kind of a teaser for you all, I think what is really important is that we continue to build these collaborations and partnerships and share experiences. Like I said, we have the large global online platform dedicated to sickle cell disease and sickle cell trait education. And a lot of patients are on social media. A lot of patients, surprisingly or not surprisingly, will feel comfortable sign up for a study or learn about a study based on what they see on social media. So we try and make sure that we can provide those resources on social media as well as on our research platform as well, and engage with the community to really help address their concerns. One of the things that we always try to do is, create all of these different studies and partnerships in a patient-friendly language, like I keep highlighting because I think it's a big and important part of it. But we also make a big priority to share back whatever studies that we run, whether it's a survey or whether it's a clinical trial that our partner has done, recruited and completed that study. I think that's a good thing that we can all do to make the community feel like whatever they participate in, at least they get to see the end result. And I think for us as a research community, we can do a little bit better with that. So that's all I have for today. Again, I encourage you all to visit www.scdstudies.com to learn more about this research platform. And please feel free to reach out and ask any questions at research@sc101.org. Key takeaway here is that there's a lot about research that we can talk about, clinical trials, all of these different gaps in research, but the patients are always at the forefront. And we want to make sure that when we present this information to them, it is very patient friendly and they can ask all their questions and hopefully we can address all those questions. So that's all I have for today. And I'm open to all questions. So thank you. And hopefully I didn't take too much time.
Thank you, Dr. Boateng. I know we are over, and again, this is a lot to process, and we will be having a part 2 with Q&A, but I would love to give the final word to Dr. Desai, our other co-chair for the Research and Clinical Trials Working Group, who shared very similar sentiments in the chat. So Dr. Desai, please feel free to close us out with any final remarks.
Well, thank you very much. Again, a wonderful way to end and talking about putting the patients first as we talk about and we summarize what we've learned today. We've learned some kind of universal themes across all of the countries about where the patients are, and we find that across the globe we're in some ways more similar, and in some ways we have some stereotypes of how things are across different regions of the world that may not be true. What the perception is of clinical trials, we need organizations, and we need this overarching themes such as Sickle 101 to look and help bring this research to our patients. And so I think this is a very important and timely discussion. So I look forward to this next session. Thank you all that are in different time zones for coming and staying up late. And thank you for everyone that participated and watched for being a part of things. So have a wonderful day, and we look forward to part 2.
Thank you all. Have a great day.
Thank you so much. Take care.
Thank you. Bye-bye.
All right.